today everything you actually need to know about methadone, both what it is and contextualizing the history of substance abuse and addiction treatment. In addition, I am answering, I hope, a viewer's question that has been waiting for this for a while. I wanted to wait to be able to contextualize this in my recent introduction of the concept of euphoria, why it's important, why methadone is more important than ever in the era of fentanyl. Let's get started. Got a couple of slides here, and at the end of this, you will know what you need to know about methadone for the most part. And I'm going to follow this up with more interesting, in depth dives into methadone and the historical evolution of methadone. I'm sorry, these slides are quick and dirty. I pulled them from some of my other talks, but I wanted to use this and they will serve the purpose that we need here. Here we are. Methadone. Uh, uh, what is it? Well, as everyone knows, it is often presented to people. It is seen in methadone clinics, which are federally regulated uh, clinics for substance abuse, replacement for whatever your opiate of choice is, and its maintenance medication. What people may not know about methadone right off the bat is that it's also used for pain in pain clinics. And I often run into this where someone will come to me and say, "Oh, I have chronic pain. I'm on methadone and I want X, Y, and Z." And I'll say, "Oh, what is your dose? Where do you get it?" And, and they tell you the methadone clinics is where they go and it's liquid and they tell you the dose 70, 80, 90, 100. If you're actually in a pain management clinic getting methadone, it's going to be pills and they're in 10 milligram tablets and they're usually not that high. Okay, so it's used for pain. But it's not regulated in that arena, and it's also in the U.S. given for substance abuse at federally regulated maintenance methadone clinics. What's the history of methadone? In future videos, I'm going to get into this much deeper, and it's a very interesting and educational. But briefly, this stuff came around in the late 30s, okay, and it was again invented by Germans, two German chemists. And Max and Gustav is this guy's name. I can't pronounce his last name ever. Bockmo, whatever. These two guys, and what was it that they were doing? Why did they do this? It was actually a response that during that time, during Nazi Germany, there was always, and during the war, there was a shortage of morphine, and other nations think of it as sort of a embargo. They wouldn't trade with them, give them morphine, and they were looking for a good, solid pain medication, and they came up with morphine. Okay, I'm sorry, they came up with methadone. Okay, it's a fully synthetic opiate agonist. Okay, a partially synthetic opiate agonist is heroin. Okay, fully synthetic opiate agonist is some of the pills you take, oxys. Another one is Suboxone or buprenorphine. Okay, and opium, if you're smoking it, that's a natural opiate, And so methadone is a fully synthetic opiate agonist, okay? And it's kind of interesting. The first thing they called it was Host 10820. And later on, it took on the name of Amidon, and it was distributed through Europe as such. What happened is the Allies won the war. The U.S. came in, and amongst all the negotiations and things the U.S. got, some things the Soviets got, U.S. gained the patent for methadone. Keep in mind, methadone was made to treat pain because of a shortage of morphine. Okay, and so what happened? Eli Lilly, you've all heard of that. They got They got methadone. They introduced it as what a name many of you may know, Dolophin, right? And dolor, pain, ends pain. And they introduced it as a pain medication originally in the US. That's how it was marketed, a long acting pain analgesic. Okay. And the Europeans also took it on with a different name, Polamidon. And there's no use of it at this time, at least in the 50s and most of the 60s. as a maintenance medication. It was a long acting pain medication invented by the Nazis. What's interesting is they also invented heroin, and I'm going to get into that history in a future video. Okay, so what happened then is at some point, this guy, Vincent, Dr. Vincent and Marie, right? They actually realized they were at Rockefeller University on the East Coast. They realized that because of the fact that methadone is long acting, it could serve as maintenance or replacement for heroin. Okay. And it actually technically was the first sort of, I don't want to say branded, but conceptualized treatment, and sort of also solidifies that chronic model disease, right? Whether you're down with that or not, and I've said in other places why that's of value, it really solidified that concept and eventually started to be marketed uh, for maintenance treatment for addiction. And the first people that figured this out are these two doctors, researchers at Rockefeller University. Um, Eventually, Europe followed suit, okay? And first, the British, Germany, and they started to introduce methadone maintenance programs in the late 60s and 70s. And what the difference was between the European introduction and, in 1972 is when the Americans, had federally regulated methadone clinics established, which also had some counseling in there and very, very strict dosing oversight. This is important to understand because while the Europeans approached this as a humane public health initiative with those thoughts in mind, okay? And eventually, even to this day, have better outcomes than us in terms of retention. We approached it almost in a punitive, uh, purgatory style, right? The way methadone clinics are set up, as some of you may know, are highly regulated, but they're privately owned. They're overly structured. And that's where that concept of liquid handcuffs comes. They're overly structured, highly regulated. And it was almost like if you really think about it, when you're not approaching a disease, a mental health issue with that idea, with public health data, research, policy, initiative, emotional and cognitive approach, you're approaching it as a law enforcement punitive thing. That's important. That's important how things have turned out to this point. And I just want to bring that into your thinking. Even the fact New York was one of the first places that established a methadone clinic. These things back in the day, guys would have to get up, and they still do to some extent, 4 or 5 in the morning and get to the clinic. That's extremely disruptive for someone trying to live a life. And the reason it was kind of put early on is a lot of these guys were blue collar workers, maybe working on the docks, factories, had heroin issues. They had to be at work at 6 a.m. Got to get up at 6 every single day, 7 days a week back then to get to the clinic. Keep that idea in mind, and it's important for a million different reasons. But for now, what I'm just simply pointing out is two American doctors at Rockefeller University's 60s realized that the long acting component of methadone can make it a fantastic replacement therapy for opiate addiction, and one can get results. Up to that point, it was simply used as a long acting pain medication. And the Europeans were doing the same early on, using it for long acting pain medication, but they soon adopted this very well grounded idea and concept that was kind of born out of research and these guys' great theoretical minds, and they adopted it, but not in the same way we did. They're not methadone clinics in that way. And in fact, many countries you can get it in a doctor's office. I wanted to pause there and point that out. What is it for the most part, and some attributes of it? Look, it's a full agonist, just like oxys, just like heroin, just like opium, right? It's a full agonist, and this is what makes it different from Suboxone and makes Suboxone or buprenorphine very unique. It's a partial agonist, agonist antagonist, whatever you want to call it, right? This lends it very different properties. What makes it work is the fact that it's has a pretty strong binding and it's long acting, but it's a full agonist. Okay, this also in a video which I'll get into probably it's in the next week or so. It's tricky titrating it and the dosing, the way your body metabolizes it, the pharmacokinetics, the pharmacodynamics, give you a lot of variability for a lot of different people. It has some cardiac issues. It's called prolonged QT, and this can, it's an electrical issue and can cause arrhythmias and your heart stopping. It's usually at higher doses. And as I've already discussed, the liquid handcuffs were the old school guys used to call methadone, because you got to get up every morning and go to the clinic. And it's really more of a law enforcement, punitive kind of a feel that, at least in the early days and to a great extent nowadays, than it is a public health compassionate approach to treating substance abuse. Okay. So I'll leave that at that. There's more videos on methadone coming, I think, the next few days or couple of weeks. Uh, for all those that talk badly about methadone and how horrible it is, it's bizarre to me. People still don't get what it is that they're escaping. Until opiate use or heroin is decriminalized, what you're going to get out there is from a drug dealer, and it's a illicit lifestyle that'll kill you, as we're seeing. And so those people that talk bad about methadone or medication assisted treatment and so forth, look, that data is clear. We got, like, what do we have, 40, 50, 60 years of data. Reduces mortality, death, 50 to 70%. Okay, decreases relapses and use. Okay, it clearly reduces criminal activity in the locales where this was introduced. Okay, lower HIV rate by 50%. This was a huge deal in the early 90s, late 80s. Okay, people were dropping dead like flies, and this is often overlooked by people nowadays because they don't see what the HIV epidemic did, and all the drug addicts were needle users. Okay, it absolutely, by data, improves social functioning, staying in your job, family, parenting, social integration. I don't think we realize the importance of these things, whether you're thinking about what it saves society in terms of financial costs, but the wreckage that happens exponentially as you affect other people's mental health, and especially developing children in those households. It's the most bizarre thing to me that we can't understand this and we see nothing except what's in front of us. We just don't care. We don't give a shit. Um, it's great mental health wise, also improves mood, anxiety, suicide, all of this stuff. Okay, when they have good dosing. And historically, and I will tell you there's other better medications that could be used, but it improves pregnancy outcomes under watch of somebody, where you can reduce the impact on the fetus and the newborn child. And it is extremely cost effective, dollar for dollar, what you spend for that versus someone being an addict. And we haven't even calculated the social outcomes and the people around the addict. And I would say it doesn't, every dollar spent on methadone, it says it's $4 to $7 in healthcare and criminal justice. And I'm going to say that number is probably somewhere between $15 and $30 if you were able, and there are studies to uh, measure the cost of the impact of your children, your family, loved ones, productivity at work, and so on. It's not even a discussion. If you think it is, that's your emotions thinking, not your critical thought. And I say this because some of the comments I get on Facebook are so beyond being in this world, it's almost impossible to respond to, and there's no need because you can't change people's minds. Okay, some of the bad stuff, adverse effects, limitations. Obviously, it's a full agonist, right? You can certainly overdose on it. Sedation, constipation, like all opiates. The weight gain and sweating is not too much of a deal for most people. I've ran methadone clinics. I started a methadone clinic in Hollywood. Uh, the QT prolongation, which I discussed, right? Sexual dysfunction, libido, which is already the case with opiates. This is silly. Oh yeah, dependence and withdrawal. When you stop, this is silly, right? Because you know the patients are the addict to opiates, right? And this can be done nowadays. There's so many tools this available for us. It's just most practitioners in the field of addiction and the world of addiction have no idea these exist or know how to approach these issues at all. Um, there is an overdose risk by itself if it goes really high, but it never does. But when you mix it with, it's synergistic with benzos, alcohol, other CNS depressants. Um, and also, what I've already discussed, regulatory and access barriers, whether it's, at least in the US, whether it's getting there or the highly structured dispensing and the hoops that the clinic even has to go through. And I'm not sure how I feel about the fact that these are privatized, which I think has a lot of impact on the full spectrum of care that they could be delivering. Don't want to get into that. This is an overview of methadone. If you guys are interested, I'll keep putting out methadone videos, dig deep into it, but there's so many wonderful topics. Look, Suboxone versus methadone in the fentanyl era. Several years ago, my position has always been that, look, methadone is important, okay? It is needed, but for every 100 people that have been traditionally on methadone, you could probably reduce that by 75 to 90% nowadays with Suboxone, the new improved drug. It is an easier drug to deal with as far as physiologically and clinically. It's also easier to access. And I was always a fan of it. And, I've always described methadone as just a heavy drug, man, getting someone on there, right? But I've changed my position in the fentanyl era, right? Because as some of you have been watching, I've described this sort of uh, euphoria, right? The kind of missing issue in attempting to treat something as potent and addicting as fentanyl, which has a very crappy euphoric point and very short as someone goes from doing fentanyl and getting to the nod off or overdose stage versus heroin. And when you try to get people on Suboxone because of that potent tenacity of fentanyl, not being able to let go of it. And when you do, that potency overtakes that euphoria that people may have originally been looking for with heroin. It's a concept that I'm developing, Euphoric Index. And if you look at my last couple of videos, I really explain that. So, that being the case in an era of fentanyl with so many overdoses, I think methadone has taken a much bigger position in the one or two things that we can prescribe for medication assisted treatment in the United States. My overall position is actually we need a much bigger arsenal in the era of fentanyl. But given what we have, Suboxone and methadone, I don't consider naltrexone injection as medication assisted treatment. There's other videos for that I can do, but these are the two, and I don't think Suboxone is going to cut it for as many people as it used to because of fentanyl. That being said, I still believe because of its ease of access, and the fact that I think it's a sort of a new and improved drug in terms of its impact on your body, potential to overdose, mix benzos and other things with it. I think one should still try to get the patient on Suboxone first. If that fails, methadone is an option that may get you there. And in fact, with methadone, it's not the greatest euphoria. It's just better than Suboxone. And it's a heavier drug, so people can potentially get on it, stay on it. And it's easier to get on than Suboxone in a time where fentanyl has such a grip on people. And to point out that methadone is not the greatest euphoria, that's why people on methadone in the 70s started taking Valium to get that extra edge of the high, which I just spoke about in another video or podcast. And that's why people started adding the heroin from the Mexicans in the early 2000s to get that extra edge of the methadone. But given the fact that we just have Suboxone and methadone, my position now is that we need to be utilizing methadone a lot more than, and it needs to be more accessible to the practitioner. Here's what's also interesting before I sign off. Check it out. All the people that criticize us physicians, that slaves of the pharmaceutical industry. I want to get people in for Suboxone. Look, I don't want a methadone clinic anymore. I have no stake in this issue, right? And I'm telling you that more people may need methadone over Suboxone. I dish out Suboxone. So for any critics out there, you're actually not in this planet. I don't get paid by the pharmaceutical companies. That's illegal unless if I declare it and it's for very specific purposes. And I certainly don't make any money telling people that maybe you need to be getting on methadone. Taper and things like that are a different issue. That's it. I hope this covers methadone enough for you to get a grip on it. I'm going to be making some more videos. Please leave a comment below, leave a like, and subscribe to the channel. I'm trying to get the channel up to 100,000. I've been away off and on for a while. I have rebranded, relabeled. It has slowed my uh, growth, and we will get there. But your support is important, and it doesn't cost anything. Click subscribe, the like button, leave a comment below, and I can do more of these videos, higher quality of production, and more topics. Peace.